This is part 1 of the Diagnostic Nuclear Medicine presentation by Pranathi and Shreya. I apologize if the order of the slides is a little bit different from our handout. We're currently in different places right now. So what is diagnostic nuclear medicine? Nuclear medicine using radiopharmaceuticals and internal radiation to diagnose patients. Radiopharmaceuticals are substances that are mixed with radiation to help doctors diagnose patients. And internal radiation is the intake of radiation through inhalation, ingestion, injection, etc. So most other forms of medicine use external radiation for diagnosis, for example, X-rays. And because radiation can be harmful, the patient's dosage is carefully administered and regulated in diagnostic nuclear medicine. There's two different types of diagnostic nuclear medicine. There's imaging, in which radiation is injected into the patient and changes the problematic area to a bright color. And one example of this is a renal scan. In a renal scan, a radiopharmaceutical, also known as a tracer, is injected into the kidneys. The kidney's reaction with the radiopharmaceutical is captured on a gamma camera, and lastly is shown on a computer for the doctor to see and use for diagnosis. There's also myocardial perfusion imaging, in which a tracer helps detect problems with blood flow to the heart by brightening the areas where there's high blood flow and darkening areas of low blood flow. The second type of nuclear medicine is non-imaging, in which there's radiation from a sample of the patient, and it's compared with external radiation. So one example of this is blood volume test. In a blood volume test, a sample of blood is taken from the patient, and the radiation in it is compared to an external radiation sample. This can help doctors detect hypovolemia, hypervolemia, etc. The second type of non-imaging one example is iodine therapy, in which I-131, also known as radioactive iodine, travels to the thyroid to kill cancer cells and leaves the rest of the body unaffected since it can only permeate thyroid tissue. This helps detect thyroid cancer. So the history of diagnostic nuclear medicine. These are just some monumental times. There are several other examples, but in 1897, Marie Curie dubs Becquerel's uranium rays radioactivity. In 1924, George de Hevesy, J.A. Christensen, and Sven Lomholt did the first radio tracer studies using rats. In 1939, Joseph Hamilton, Mayo Soli, and Robley Evans wrote the first paper on diagnostic uses of radioactive iodine. In 1962, David Kuhl produces emission reconstruction topography, also known as PET and SPECT. In 1989, the FDA approved the first positron tracer for myocardial perfusion imaging, and by 2001, in the U.S., 16.9 million nuclear medicine procedures had been performed.
Second part of Pranathi and Shreya's Diagnostic Nuclear Medicine presentation. So I'm going to start off with some underlying scientific topics, or basically how diagnostic nuclear medicine works. Just to review, diagnostic nuclear medicine is a branch of medicine where a diagnosis is derived from a computer, camera images, which is based on energy from radioactive material. So how does this radioactive energy form these images? The main idea is that the release of radioactivity from radioactive isotopes come and hit a camera and attract it. Most of these radioactive isotopes release photons, and those rays attract the camera, drawing it closer and drawing images. Also, some things to note is that radioactive materials often in imaging are called radioactive tracers, or radiopharmaceuticals. Some examples of common tracers are technetium-99, a common tracer that has a half-life of 6 hours, and another one is iodine-131, but that's also used in therapy. one can see below in the picture, it says radioactive atom and energy. You can see a photon being emitted as the ray through energy, and that will eventually attract the camera. So before, Shreya had talked briefly about the different types of nuclear medicine, imaging and non-imaging. However, I'm going to focus on some different imaging tests of nuclear medicine. Planar scintigraphy is 2D imaging and has been around quite a long time because it's simple and computer technology was able to catch up with it quite easily. Single photon emission computed tomography, SPECT, is cross-sectional imaging of a body using single photon emission tracers. Also, we have positron emission tomography, which is quite similar, except for the fact that a PET scan utilizes positron emission, while a SPECT scan utilizes a single photon. Another thing to note is that computer technology was quite slow, so these two have become more common in recent years as computer technology has rapidly increased. Another thing to note about PET and SPECT is that they are initially taken as a single axis or plane of a body. That's how the camera initially images them. One way to imagine this axis kind of thing is imagine a single slice of a body, like ham or bologna. Though, when they're processed and put into a computer, they're taken as a multiplanar image, producing much more complex things for doctors to read and diagnose a patient upon. Left ventricle ejection fraction. So, the left ventricle ejection fraction is a calculation quite commonly used in nuclear medicine diagnostically, basically during a MUGA scan, a scan in which is taken of the heart and is usually used to identify cardiovascular problems. But this fraction helps a physician identify the functionality of the left ventricle chamber of the heart and how it's affected by the radiation. So, here's the initial formula. EF, or ejection fraction, is the end diastolic counts minus the end systolic counts divided by the end diastolic counts minus the background. So what do each of these mean? First off, let's start with counts. Counts are the number of photons measured within a particular region, in this case the left ventricle, and at times, or in other words, during a specific phase, diastolic or systolic, as mentioned here, but also during the background. So to explain the phases, diastolic is the relaxation phase of the heart muscle, while systolic is the contraction phase. And background, to imagine it simply, it's just photons from the non-target region, the left ventricle at the time. They're in the background and they're still there, so they should be taken into account for precision purposes, mainly to the end diastolic counts. The formula results in a percentage. Even though it's supposed to be an ejection fraction, the percentage is more easy to visualize the functionality of an organ. Not of an organ, but of a tissue. So an example of this formula being used can be seen here. A MUGA scan shows that a patient has 10,000 end diastolic counts, 6,000 end systolic counts, and 300 background counts. So to compute this simply, one can see that the EF equals 10,000 minus 6,000 counts, divided by 10,000 counts minus 300 counts. When this is simplified, one will get 4,000 counts divided by 9,700 counts. At this point, once those two numbers are computed, one would get the fraction or decimal or ratio 0.41237 as it runs on. But to simplify this down to a percentage with the correct number of sig figs, we will have 41.24%, showing that function going down. So what is the social impact of nuclear medicine? There are many issues taken with nuclear medicine, mainly ethical. However, these ethical issues are mainly therapeutic. Why will be explained later, though many people note that the benefits outweigh the risks, though once again mainly in therapy, and that radiation goes only a short distance after intake, not harming distant tissue. That's another benefit that kind of backs up and supports that, why benefits outweigh the risks. However, it can still hurt tissues if not given in the right dosages or if a mistake is made, and there's always that psychological thought of, oh my god, radiation is going to harm my body, it's going to change my cells. Potentially even forcing many to think that they may catch cancer, or not catch cancer, get cancer, or something of that matter. The reason this is mainly taken into account with therapy is because the dosages are often higher than with diagnostic, because diagnostic is simply taking a smaller test with a much smaller injection. One thing more concerning diagnostics, though, is regulations. There have been regulations, just in general, making things more modern and giving more freedom to doctors, institutions, patients, and researchers. One of them is that in 1997, the Modernization Act by the FDA made PET scans far more common. As I mentioned before, the computer technology had not catching up, and here it is catching up. In addition to it being influenced by that computer technology, it's also due to the fact that people want to research more, go out more. Also on the topic of research, new drugs, or EINDs, which is defined as an emergency investigational new drug, which is also based off of research, may allow some physicians to get more tracers, not may allow, but may push more physicians or researchers to use tracers that go further, do more harm, and potentially may risk some things. Now, with the rampant thing of more physicians and all those people going out and doing more, many people, including the FDA and many physicians, want to regularize and standardize all the rules because it makes it far easier going from institution to institution, and more than that, the risk can be standardized. And some institutions may do some risky and questionable things. So that is something to note. So some discussion questions, which Shreya may or may have not gone over, is why is nuclear medicine imaging so advantageous to doctors? Is because one can literally see and diagnose rather than just having some fatal random image or based off of symptoms or something else. They can literally see something if it's a tumor, ruptured blood vessel. Well, maybe not so specific as to the ruptured blood vessel, but they can often see areas of interest which make them question and lead them to ideas of potentially what disease a patient may have. What are some issues with hospitals having different regulations on the administration of radioactive tracers, and how does this affect the patients? As mentioned before, the physicians may feel that some decisions are risky and whatnot, and also, even though I did not directly try it in, one thing to note is that patients, once again, do have that psychological impact. And that may affect them into thinking, oh my god, more radiation being emitted into my body, cancer, potentially? And what impact has PET and SPECT had today? One may recall the statistic mentioned earlier on in the presentation of over 16 million scans being done by 2001. Even though that's not a recent statistic, that was 15 years ago. Imagine with the computer technology we have today, how many more people could have been diagnosed, saved, and problems could have been detected earlier. Once again, even with the tumors and more people noting earlier stages of cancer. So that is all for today with our presentation on nuclear medicine. As one can see here, these are all of our sources, though I hope you all learned a lot about nuclear medicine, specifically in diagnostics and imaging, and enjoyed it. Thank you.